Hello, my name is SaiCharitha-PM1SA1. This is my presentation where I'll discuss cetuximab, also known as IMC C225. The epidermal growth factor receptor or EGFR is a transmembrane receptor and a member of ERBB family of tyrosine kinases. When activated by ligands such as EGF or TGF alpha, EGFR dimerizes and activates downstream pathways which regulate cell proliferation, survival, angiogenesis, and differentiation. In cancer, this pathway is frequently overactive. EGFR is overexpressed in a majority of colorectal cancers and in many lung and head and neck cancers. Overexpression often correlates with aggressive tumor growth and poor diagnosis. To detect EGFR in patients, several techniques are used. Immunohistochemistry is the most common method to access protein expression in tumor tissue. Fish can detect the EGFR gene amplification. PCR and DNA sequencing are used to detect specific mutations in the EGFR gene. These molecular diagnostic tools help decide whether a patient is eligible for EGFR targeted therapy. Patients with EGFR positive tumors can be treated with two main classes of drugs. The first class is monoclonal antibodies such as cetuximab. These antibodies bind to the extracellular ligand binding domain of EGFR, preventing the natural ligands from activating the receptor. They can also trigger immune mediated killing of tumor cells through antibody dependent mechanisms. The second class is tyrosine kinase inhibitors or TKIs such as gefitinib or erlotinib. These small molecules that block the ATP binding site on the intracellular kinase domain of EGFR, preventing the downstream signaling. Both approaches have been successfully used in cancer treatment. Cetuximab is approved for colorectal cancer, head and neck cell carcinomas, while TKIs are widely used in non-small cell lung cancers. Together, these strategies demonstrate the power of targeting EGFR in precision oncology. Cetuximab was derived from an earlier murine monoclonal antibody known as MAP225, which bound to the EGFR. To make it suitable for human use, scientists have engineered a chimeric antibody IMC-C225, combining the variable regions of the murine antibody with human constant regions. This reduced immunogenicity and increased clinical safety. The drug binds with a high affinity to the extracellular domain of the EGFR, blocking the binds of ligands such as EGF and TGF alpha. This prevents the receptor activation, dimerization, and downstream signaling. In the preclinical paper 1 review, the researchers used the flow cytometry to confirm that cetuximab binds EGFR on colorectal cancer cells. They also used Western blotting to show that cetuximab effectively blocked ligand-induced phosphorylation of EGFR. These techniques demonstrated that the antibody was binding to its target and inhibiting the receptor activity. The most important results come from the in vivo studies in colorectal xenograft models. Using DLD1 and HT29 in mice, when cetuximab was given alone, tumor was modestly slowed. When irinotecan, also called as CPT11, was given alone, it was effective against some tumors but not all, with many becoming the resistance. However, when cetuximab and irinotecan were combined, the results were much stronger. In the HT29 xenograft model, the tumor regression occurred in up to 100% of the animals, and in DLD1 model, up to 60% sure regression. This demonstrates a synergetic effect between the antibody and the chemotherapy. Histological analysis provided mechanistic insights. Tumors treated with the combination of showed extensive necrosis, reduced proliferation as measured by Chi67 staining, reduced vasculate shown by CD31 staining, and increased apoptosis by tunnel staining. These findings confirm that the drug works by both direct tumor cell killing and disrupting the microenvironment. These graphs investigate the direct and indirect mechanisms of anti-EGFR antibody on cancer cells. The figure 1 here demonstrates the direct anti-tumor effects, that is proliferation and apoptosis. Cetuximab significantly slowed down the cell division, whereas the drug actively induces the programmed cell death. In the figure 2 here, it demonstrates the indirect anti-tumor effects cetuximab causes a dose-dependent reduction in secretion of vascular endothelial growth factor, that is VGEF, by H29 tumor cells. One of the key lessons from the study and subsequent clinical trials is that not all patients respond equally to cetuximab. Later studies showed that patients with KRAS mutations in colorectal cancer do not benefit because KRAS mutations activate downstream signaling independently of EGFR. As a result, KRAS testing is now mandatory before prescribing the cetuximab. This is a great example of precision medicine in practice. By screening the patients for EGFR and KRAS status, we can avoid giving the ineffective therapy to non-responders, spare them with the unnecessary side effects. In conclusion, EGFR is a validated and important therapeutic target in cancer. Cetuximab, developed from a murine antibody, showed a strong preclinical activity when combined with the irinotecan in colorectal cancer xenografts. The results demonstrated significantly tumor regression, increased apoptosis, and reduced angiogenesis. Most importantly, the development of biomarkers such as KRAS mutation testing had transformed the cetuximab from a general treatment into a precision medicine. This has been improved patient outcome by ensuring that not only to benefit receive the drug.